causes of hyperkalemia and talk a little bit more about specific physiology in hyperkalemia. And I think this differential is very familiar to nephrologists, but we think of increased intake as playing a role in hyperkalemia. Really, it's very hard to see this as being a cause of pure hyperkalemia in patients who have normal renal function. You have to take in tremendous amounts of potassium to develop hyperkalemia in the setting of normal renal function. However, I think we all appreciate that patients that have a reduction in renal function or hormonal abnormalities that affect their ability to secrete potassium are very susceptible to changes in potassium intake as a cause of hyperkalemia. Regardless, very high K supplements can play a role. Dietary factors plays a role. Transfusions of blood, particularly with older blood, can cause hyperkalemia. And obviously, if we over-replace patients with KCl or potassium chloride, those patients can develop hyperkalemia. Decreased renal excretion plays a very major role in hyperkalemia. Obviously, renal disease plays a big role, particularly in those patients with type 4 renal tubular acidosis or hyporeninemic hypoaldosteronism, which I'll review in a little bit more detail later on. There's a large group of drugs that can reduce K excretion. We'll talk about them in a minute. Adrenal insufficiency clearly can cause a reduced renal excretion because of the low aldosterone bioactivity. But again, this theme that hyperkalemia is not universal in patients with adrenal insufficiency because there are other factors other than aldosterone that regulate K secretion. You can develop hyperkalemia due to a shift of potassium from the intracellular space in muscle to the extracellular space and extracellular fluid volume. As I mentioned, you can see that with hyperosmolality. You can see it in insulinopenia. You can see it in metabolic acidemia, but notably not with anion gap acidosis. So lactic acidosis does not cause hyperkalemia because of the metabolic acidosis. And the thought is that because there's this accompanying anion that makes an electroneutral switch, that driving force for potassium to come out of cells is not present. There are many other unusual drugs that cause an exchange of potassium. This seems to be mostly a potassium or an apparent potassium proton exchange. You can see that with certain potassium channel blockers. You can also see it with lysine and with amicar, which is epsilon aminocaprylic acid, which is structurally similar to lysine. So they cause a potassium proton exchange that causes hyperkalemia. And finally, there are very many artifactual causes of hyperkalemia. If you have in vitro hemolysis or leukocytosis or thrombocytosis, where plasma potassium is normal, but serum potassium of clotted blood is elevated. There are also many different other forms of genetic or acquired pseudohyperkalemia. For those that are interested, the Brennan-Rector chapter has a very long discussion of those disorders. We mentioned that drugs are an important cause of hyperkalemia. Most of those drugs do so by interfering with the renin-angiotensin-aldosterone axis. So as we'll talk about, renin secretion by the kidney is tightly regulated by the kidney, and it can also be regulated by many different drugs. These include NSAIDs and COX-2 inhibitors. The renin inhibitor aliskiren can play a role. Beta blockers and calcineurin inhibitors can also cause a reduction in renin. ACE inhibitors obviously reduce the generation of angiotensin II from angiotensin I. Angiotensin receptor blockers can block the signaling effect of angiotensin II. When we get to the aldosterone effects, the aldosterone or mineralocorticoid receptor can be blocked by many drugs. Classically, spironolactone, canrenone, or eplerenone, but also drospirenone, which is a component in contraceptives. Drospirenone has about the amount in a contraceptive pill has about the same efficacy in terms of inhibiting the mineralocorticoid receptor as does 25 milligrams of spironolactone. So occasionally patients have been known to develop hyperkalemia on that drug. Finally, when we get to the renal tubule, there are many different ENaC blockers that are associated with hyperkalemia. These include amiloride, triamterene, trimethoprim, which is a component of Bactrim, and is structurally related to amiloride, and pentamidine, of course, which is also used for pneumocystis like Bactrim. These drugs can block the amiloride-sensitive sodium channel and cause hyperkalemia. In Japan, there's a protease inhibitor called nafamostat that is associated with hyperkalemia. There is an aldosterone-regulated protease that activates ENaC channel that it's inhibited by this protease inhibitor, a physiology that is also discussed in some of my chapter textbooks. It's key, I think, though, in our patients that we see in the renal clinic, patients with established chronic kidney disease, I would say 9 out of 10 patients, if they come in with an elevated potassium without much change in their renal function, 9 times out of 10, it's a dietary factor. They've eaten something the day before. Potassium include dried fruits, nuts, avocados, etc. But I think the biggest culprits are the foods that have a high content, such as tomatoes, potatoes, oranges, and other citrus fruits. And it's important to not just get a sense of what the patients are taking, but what quantity they're taking as well. So they may not be eating something that has a particularly high potassium content, but if they're eating an enormous amount, they will get into trouble. I'd like to go through some of the physiology of hyporeninemic hypoaldosteronism, because I do think that this is a very important cause of hyperkalemia if we think of our renal patients. And it's associated with many different disorders and really plays a big role in causing hyperkalemia. Classically, these patients have a hyperchloremic acidosis, and about 50% of the time with urine pH that's classically less than 5.5. They will have hyperkalemia. Generally, to make this diagnosis, they have to have a reduction in plasma renin activity and a reduction in plasma aldosterone. This is not, however, fixed in that you can turn this on, but in general, the response of the plasma renin activity to stimuli such as furosemide captopril is blunted in these patients. Commonly, we see this in patients that have an increased age, that are elderly and have a reduced GFR. And classically, we see it in diabetics. So clearly, if we see an elderly diabetic with chronic kidney disease, hyporeninemic hypoaldosteronism may very well play a big role. One of the important issues that I'd like to discuss today is the role of hypertension and a clinical increase in the extracellular fluid volume in these patients, because the major endogenous mediator, if we can generalize, is probably the natriuretic peptides such as ANP and BNP. When they're elevated, they tend to suppress the renal renin release, but also the adrenal aldosterone release. So they're probably the single biggest factor in many of our patients who have type 4 RTA or hyporeninemic hypoaldosteronism. And I'll go through some of the highlights of that physiology, but again, it's referenced in greater detail in my chapters. So what are the causes of hyporeninemic hypoaldosteronism? Well, classically, we see it in diabetic nephropathy, where there are additional mechanisms that aren't seen in other of these disorders. You can see it in acute glomerulonephritis. It's classically seen in post-strep GN, which we think of as sort of the classic nephritic syndrome per se. Often people talk about tubulointerstitial nephropathy, such as sickle cell disease, as being causes of hyporeninemic hypoaldosteronism. Personally, I think these are mostly defects in the target organ, either the tubular damage, rather than defects in secreted or circulating renin and aldo themselves. However, we tend to sort of think of them as part of the same pathophysiology. There are many drugs that can cause hyporeninemic hypoaldosteronism. NSAIDs, as we'll talk about, COX-2 inhibitors will show why. And the calcineurin inhibitors, cyclosporin and tacrolimus, will very definitely cause hyporeninemic hypoaldosteronism. Finally, we'll talk a little bit about hereditary causes. Dr. Gamba will talk a lot about Gordon syndrome or pseudohypoaldosteronism type 2. But in many respects, this is really a very exaggerated form of hyporeninemic hypoaldosteronism, that particular rare disorder. So if we talk about this, we do need to talk a little bit about the anatomy. So we have to talk about really the juxtaglomerular apparatus, which is the major intrarenal source of renin. So the juxtaglomerular apparatus is formed by the afferent and efferent arteriole of the individual nephron, combined with the glomerulus itself, and the extraglomerular mesangium that sits between the afferent and efferent arteriole and the tubule that includes the macula densa, which is that plaque of specialized tubular cells on the side of the tubule that's adherent to its parent glomerulus. So together, this apparatus is called the juxtaglomerular apparatus. It includes a vascular component, it includes the extraglomerular mesangium, and it includes the tubular component from the macula densa cells. It's the granular cells that are noted here that in the afferent arteriole that secrete renin, and they do so in response to hormonal and local autocrine factors that are generated in the extraglomerular mesangium and in the macula densa. So this is really a syncytium sort of autocrine regulation that ultimately turns on or turns off renin secretion. One of the major insights in the last 20 to 30 years in this physiology was the realization that what was thought to be an inflammatory isoform of cyclooxygenase, COX-2, is expressed sort of constitutively in the macula densa cells. So it plays a very important role in the regulation of both tubular glomerular feedback, the other function of this juxtaglomerular apparatus, and in the tubular regulation of renin secretion. It tends to be recruited in reduced salts and disorders such as heart failure or Bartter syndrome and so on. So it's not, strictly speaking, a constitutive form, a component of the macula densa, but it does play a major role in regulating renal tubular renin release. Specifically, if you think of the macula densa cell, it has NKCC2, the NAKCl cotransporter. Tubular chloride is the major signal that is regulated, that is sensed by macula densa cells. That turns on the release of arachidonic acid. COX-2 then generates prostaglandins, specifically PGE2, PGI2. Those diffuse locally, and in the juxtaglomerular cell, they turn on their cognate receptors. That turns on adenylate cyclase, which increases the amount of cyclic AMP, and that then increases renin secretion. In general, receptors that turn on pKa will tend to turn on renin. So beta receptors, for example, are a classic example of receptors that are in juxtaglomerular cells that turn on renin secretion and can be inhibited by drugs. But this relationship between the macula densa and renin secretion has very important clinical relevance. So this figure is taken from one of the early papers many, many years ago on hyporeninemic hypoaldosteronism in response to an NSAID. So this was a patient with renal dysfunction, I believe due to lupus nephritis. She had a sort of chronic kidney disease, and she'd been presenting with hyperkalemia due to indomethacin. At the top left, you can see she was on indomethacin with a high serum potassium. As they stopped indomethacin, her potassium came down. As her potassium came down, you could see this increase in her renin, peripheral renin, and an increase in her plasma aldosterone. And you could see an increase in her urinary aldosterone. And at the same time, you would see this, they saw this increase in urinary prostaglandins. So this physiology where if you inhibit this axis, if you inhibit COX-2 in the macula densa, you then will inhibit renin secretion and cause hyperkalemia. That's a very important theme in terms of many other drugs, in particular the calcineurin inhibitors that also downregulate COX-2 in the macula densa and cause hyperkalemia, at least in part due to this mechanism. One of the important issues, though, is we think of renin from the kidney as turning on aldosterone through angiotensin II, so that we're really secreting an enzyme, renin, that has an effect on another organ, the adrenal gland. We tend to forget that the adrenal gland in and of itself responds to serum potassium by releasing aldosterone. So if you take adrenal glands and elevate their extracellular potassium, they release aldosterone through a signaling mechanism that is not directly dependent but modulated by the renin-angiotensin axis. So this is shown here. If you took a look at adrenal release, aldo release, by adrenal cells in response to an extracellular potassium of 5 versus 2 millimolar, you clearly have much more aldosterone released in the glands that are exposed to a higher potassium. But if you look at the amount of, if you increase the amount of ambient angiotensin 2, you also see an additional activation. So there's this synergistic regulation of adrenal aldo release in response to angiotensin 2, but also in response to extracellular potassium. One of the major events of the last decade has been the realization that the signaling pathways that regulate this adrenal aldosterone release play a very important genetic role in the generation of adrenal adenomas, as we'll talk about. The other issue, though, is that if you give somebody a renin-angiotensin axis inhibitor, a RAS inhibitor, such as an ACE inhibitor or an ARB, you will be blunting the adrenal release of aldosterone in addition to blunting the renal release of renin. So this is shown in rats that were sodium restricted, and they looked at the perfused adrenal gland. If they took the adrenal gland out of normal rats, you would see this increase in aldosterone release in response to hyperkalemia. If they took the adrenal gland out of animals that had been pre-exposed to captopril or cerulazin, which is an angiotensin receptor blocker, or losartan, their response to hyperkalemia was also blunted. So clearly then the issue is that you need an intact local and systemic renin-angiotensin aldosterone axis to be able to respond to hyperkalemia in the adrenal gland. So it's not just a renal phenotype, the hyperkalemia that you see with ACE inhibitors and other drugs. The other issue is this role of endogenous ANP or BNP in regulating renal renin release and aldosterone release. For those that are interested, there were many papers in the early 90s from the Beth Israel Hospital by Barbara Clark and Dr. Epstein that looked at the regulation of the renin-angiotensin axis in elderly patients with hyporeninemic hypoaldosteronism. So this shows 4 of these patients that were in their 80s and 90s that all had some degree of hyperkalemia. They had some degree of renal insufficiency, some of them. They had relatively low adrenal aldosterone levels, but not uniformly low. And they had suppressed renins consistent with hyporeninemic hypoaldosteronism. They also all had very high levels of plasma ANP, suggesting that they were slightly hypervolemic. And this contrasted to elderly controls who had much lower renin and also slightly lower renin and slightly lower aldo, but clearly they did not have the high ANP. If they compared these older volunteers to younger volunteers, when they infused potassium into these subjects, they weren't patients per se, you could see an increase in serum aldosterone. So if you infuse potassium into subjects, you see this burst in adrenal aldosterone release. Both the older subjects and the younger subject had the same curve in serum potassium in response to intravenous potassium. But the younger subjects had a much higher aldosterone release in response to hyperkalemia. However, if you look at the younger volunteers and then infuse them with ANP at the same time that you're giving them a potassium load, you completely abrogate their adrenal aldosterone release. So if you see here, the ANP did not affect the increase in potassium due to a potassium load, but it completely abrogated this increase in aldosterone in response to ANP. It's also known that ANP inhibits renal renin release. So in patients that are hypervolemic with a high level of brain and atrial natriuretic peptide, they will have an inhibition of renal renin release and also of adrenal aldosterone release, contributing to their hyporeninemic hypoaldosteronism. So for this part of the talk, the take-home messages that I wanted you to come away with in terms of the renin-angiotensin-aldosterone axis in hyperkalemia is this role of ANP, systemic and local renin-angiotensin axis, and prostaglandins. I didn't show this, but prostaglandins and prostaglandin receptors also modulate adrenal aldosterone release in the same way that angiotensin 2 does and other hormones. All of these affect renal renin release and adrenal aldosterone release. So remember this adrenal effect when you think of hyperkalemia. And we talked a little bit about the role of in hyporeninemic hypoaldosteronism of volume expansion and an increase in ANP and BNP. That leads to a reduction in renal renin and a reduction in adrenal aldosterone release. And this, clearly we think of the risk of hyperkalemia as being very high in renin-angiotensin aldosterone axis inhibition, particularly when we combine multiple RAS inhibitors. Now, at this point, we don't really give both ACE and ARBs together, but we do occasionally give mineralocorticoid antagonists with, say, an ACE or an ARB in congestive heart failure. So there's a large component of hyperkalemia that's due to these agents, but also to mixing these agents together and giving dual agents to patients. So I've salted this talk with a few multiple choice questions. This actually came from a board review question many years ago when I took my renal boards an unspecified period of time ago. So you were referred a 17-year-old high school student for management of high blood pressure. He has not seen a physician since childhood, is on no medications. He denies drug abuse, including cocaine. He's a very strong positive family history for hypertension with a history of kidney stones in his 50-year-old father. Since you have access to a clinical research center, you admit the father and son for biochemical profiling while ingesting a diet with rigorously controlled salt content. So I've modified this question that I saw in the board exam with actual subject data from a clinical case report many years ago. And in this case report, the two patients were put on a high and a low salt diet. And on the high salt diet, 200 milliequivalents per day, they both had hypertension with a hyperkalemic metabolic acidosis to varying degrees, which was more apparent in the son. When, however, they were put on a low salt diet, that phenotype melted away. So they became normotensive, their potassium normalized, and their bicarbonate normalized. Along with this, when they were on the high salt diet, they had a low renin and a high aldosterone. They had a very high aldosterone when they were on a lower salt diet, but their renin came up. So this was clearly a very exaggerated form of hyporeninemic hypoaldosteronism. And again, in keeping with what we talked about before, they had high ANP levels when they were on high salt and a low ANP level when they were on a lower salt. So which of the following is the most appropriate therapy for this patient? Aggressive potassium excretion, sodium chloride restriction to 10 milliequivalents per day, nifedipine, amiloride, or hydrochlorothiazide. So this is one of those unfortunate multiple choice questions where you not only need to recognize what this particular phenotype is, but you need to know what the right therapy is for the disorder. So perhaps aggressive potassium excretion could play a role, but probably not. Sodium restricting patients to 10 milliequivalents a day is all well and good for a clinical research center, but is not clinically achievable. Nifedipine doesn't seem to play a role. Amiloride, well, amiloride does inhibit ENaC, and it really will dramatically affect a particular phenotype called Little syndrome. But patients with Little syndrome have a metabolic alkalosis and hypokalemia, so clearly that's not the right drug. So by process of elimination, we're left with this drug, hydrochlorothiazide, which is why we can sometimes pass multiple choice questions without really knowing what we're talking about. But that actually turns out to be the right answer, because these patients had what's called Gordon syndrome or pseudohypoaldosteronism type 2. It's also often called the chloride shunt disorder, More recently, it's been called familial hypertension with hyperkalemia. Dr. Gamba will no doubt talk about this disorder, which is very, very rare, but really has led to a great understanding of the relevant physiology. So Gordon syndrome, or PHA type 2, is really the mirror image of Gittleman syndrome that's due to loss of function in the thiazide-sensitive sodium chloride transporter. So in Gittleman syndrome, you have hypotension with a hypokalemic alkalosis, and you have high levels of renin and aldosterone, and you're hypocalciuric with actually an increase in bone density. In Gordon syndrome, however, the patients are hypertensive, they have a hyperkalemic acidosis, they have suppressed plasma renin and aldosterone, and they're hypercalciuric and tend to suffer from nephrolithiasis. This disorder, similar to Little syndrome, being responsive to amiloride, is very exquisitely sensitive to thiazide therapy. It has autosomal dominant transmission, and it's rarely recessive. And there are 5 different genes, of which 4 are characterized. And Dr. Gamba will talk about that in greater detail. But really, the pivotal event in this disorder was the initial identification of 2 of the disease genes, the Wink1 kinase and the Wink4 kinase. These are named for the lack of lysine in the catalytic center of the kinase, hence with no lysine, K being the biochemical symbol for lysine. So these are very large kinases that have homology between each other and have also coil domains and many other domains that have now been discovered over the years. But in the initial paper, they showed that Wink1 is expressed in the distal convoluted tubule, so cells that express NCC, and Wink1 is also expressed in cells that express aquaporin 2, so the principal cells. And the same goes for Wink4. It's expressed in principal cells and in distal convoluted tubule cells. And Dr. Gamba will go through some of the experiments that have gone on over the years in this with these kinases. But I think the really important single experiment was one he did many, many years ago, where he showed that the Wink4 kinase inhibited NCC, the thiazide-sensitive cotransporter. That inhibition was abrogated when you had a kinase dead mutant, and it was also abrogated by the disease-associated mutation in Wink4. So these are disorders where there's an overactivation of NCC in the distal convoluted tubule. And this has led to a greater appreciation that NCC, the thiazide-sensitive cotransporter, which is just upstream of the connecting tubule, that it's tightly regulated by potassium homeostasis and by hormones that are modulated by potassium. So on a low-salt diet, you see an activation of NCC with high angiotensin II and high aldosterone. On a normal diet, it's sort of in the middle. But if you look at hyperkalemia, you get an inhibition of NCC because you don't want to reabsorb sodium just upstream of the connecting tubule. And then you have an increase in the apical K channel, ROMK. Dr. Gamba will talk through the physiology, which is really, really intriguing in the last 2 decades, what's been discovered, both with the Wink kinases, but with some of their upstream regulatory factors. But really, this has sort of solved what we used to call the aldosterone paradox, that aldosterone was primarily regulating salt absorption, but also regulates potassium secretion. So how do you independently regulate sodium absorption and potassium excretion? Well, for one, we know that there's an increase in angiotensin II in the setting of hypokalemia and potassium restriction. That inhibits apical ROMK activity. We also know that there's potassium-dependent regulation of the thiazide-sensitive cotransporter in the DCT, thus changing salt delivery to principal cells. So you see a suppression of NCC by hyperkalemia or potassium loading, and you see an angiotensin II-dependent increase in NCC activity in the setting of hypokalemia and potassium restriction. There's also K-dependent modulation of the Wink kinases, and there's also aldosterone-independent induction of what's called electroneutral sodium chloride transport in the collecting tubule. We now know that this electroneutral salt transport is due to a very novel pathway of sodium absorption involving a sodium bicarbonate transporter and the apical chloride bicarbonate exchanger bendrin. But this electroneutral sodium chloride transport can go on without affecting electrogenic potassium excretion. And as I mentioned as well, there's electroneutral ENaC-independent K secretion primarily in intercalated cells. This physiology, for those that are interested, is reviewed in my Brenner and Rector chapter and in many of the chapters and reviews that are coming out on this evolving area of physiology.